Call to order this meeting of the Medical Marijuana Working Group. Want to thank everyone for being here again. Would like to thank the presenters who are here, most all of whom we have heard from before. This is the day when we started the group. This subject is probably the one that I wanted to go first with, because I think out of all of the things that we need to do surrounding medical marijuana, making sure that this is actual, good medicine, high quality standards, all of those things. If there's anything that we're supposed to be doing, I think that that's got to be it. So appreciate, I know all of the groups here today have put a whole lot of work into this subject. And I know the more I learn about this subject, the more I feel like I don't know. So I'm hoping that we can start to narrow down the focus and kind of figure out which direction we need to go. A lot of different states have gone a lot of different ways on this. So I want to thank you guys for being here. Wanted to thank before I forget, we've had well over 100 comments come in on the public comment email line, which I've now gone blank. It's what's the email address? SQ788, right? You don't type out state question. SQ788@oksenate.gov. So if you do have public comments, there are things that you want. Those are being read. It is not a black hole email box, but we have received well over 100 emails in this first week, and I appreciate those people who have jumped on and sent those opinions, sent those thoughts, sent those suggestions on things that we need to be looking at and talking about, and directions that we may need to go policy-wise. So with that, unless my co-chair has something to add in, we're going to jump in and get going. Today we're going to talk about testing. Basically, today we're going to talk about how in the world we go about making sure that the things that people are ingesting, the medicine that people in the state of Oklahoma is ingesting, is actually a quality medication, and how we know that we're not giving them bad product. And so we're going to start today with the State Department of Health. Interim Commissioner Bates could not be here today, but he sent the brain power, which is really all we asked anyway. And I'll tell Tom that y'all will probably text him that I said that he wasn't the brain power. But so start with Buffy, if you guys would introduce yourselves, and then we'll give you the floor. Podium, or I mean, if it's easier to do it from your seat, whichever you would rather do, we'll give you the option. Make sure you speak into the microphone, please.
Good morning. Thank you very much. And I'm pleased to be able to be here today to share Health Department's perspective and provide an overview of testing. My name is Buffy Heater. I'm the Chief of Data, Public Policy, and Promotion at the State Department of Health, and I've been charged with overseeing the implementation of the Oklahoma Medical Marijuana Authority. So let's get started. As I turn to the slide deck, I want everyone to be aware that the materials for today, we did go ahead and post those out on the OMMA website. They should be active and available under the news link. And so for the copies that have been provided here, you have not only the slide deck, but the draft of the recently recommended revised rules that were put forth by the Food Safety Standards Board, which was a statutory requirement of State Question 788. So those will be the two documents that we'll be speaking to today. All right, so what I've been asked to speak on is the kind of an overview and a history of where the Health Department has been in rule promulgation as it pertains to testing. So we recognize that there was a version of the rule that was created by Board of Health on July 10th. We also received public comments specific to testing. There was a subsequent rule revision that is currently in effect that took place on August 1st. And then most recently, in mid to late August, we had activities of the Food Safety Standards Board where there were some additional changes made or changes recommended specific to testing. So without further ado, let's go ahead and jump in. So just to put a little bit of perspective on this, we did go live with the application website on August 25th. It went live at 10 a.m. So as of about midday yesterday, there was a total of over 3,500 applications that had been submitted into the system. Of those, you see that there are 589 growers, 166 processors, and 411 dispensaries. So we see that there's no lack of business interest by the industry in Oklahoma, as is indicated by the number of applications that we received. Going on, State Question 788, just as a reminder to everyone here in the audience, the Health Department was charged with being the agency that stood up that license application process. And wanted to make sure that everyone remembered that State Question 788 did not specify any qualifying conditions for the purchase or the use of medical marijuana or to be able to obtain a license. And also, State Question 788 did not require the testing of medical marijuana products. So this is something as we move forward that we're, as the Health Department and also in conjunction with our partners here, we're going to be exploring what statutory authority may need to be provided in order for Health Department to be able to promulgate rules on that topic. I will also point out that State Question 788 did require the development of that 12-member Food Safety Standards Board. That is the one entity that was given the authority in statute to be able to come up with recommendations that would then be supplied to the State Board of Health for potential consideration through rule promulgation. Now, as you'll see later on in the remarks, that Food Safety Standards Board does have limited purview in that we are only talking about its jurisdiction, if you will, only being related to food products and products that meet that definition of food. Okay, one last quick recap, because I recognize it's been since August 8th that I believe we've been here in front of you. But from the Health Department's perspective, when Commissioner Bates was here and presented to this group that first week of August, did want to remind everyone that there were three primary public health areas that the State Health Department brought to you all for your consideration as a recommendation from the Health Department to be able to delve into. Number one was laboratory testing. We recognize that there are many other areas in food service and food manufacturing that currently have existing rulemaking authority for entities to be able to test products to ensure that they are safe for the public. So that is something that we feel should be extended also on to medical marijuana products. We also recognize the need for recall requirements. So in the event that we have a bad batch or folks start getting part of the product, we want to have mechanisms and processes in place to make sure that that product is promptly removed from circulation so that it doesn't continue to have adverse effects on people. And then the third one is packaging and labeling. So we want to make sure that packaging and labeling is not easily openable by children. We want to make sure that there are adequate warnings and cautions so that consumers who may be willingly or unwillingly coming across those products, that they're aware of actually what is in that material. Okay, so as I mentioned, let's walk kind of quickly through where we've been in the agency's rulemaking process. So on July 10th, the Board of Health did take action on an initial version of agency rule. The governor did sign those rules, but then subsequent to that, we did have the Attorney General that issued a letter to the Health Department indicating where the Board of Health had operated outside of its statutory authority. What happened thereafter was that a revised set of rule was presented to the State Board of Health for their consideration. They did act on that revised rule on August 1st, and it was subsequently signed by the governor. And then the most recent activities, which we'll talk about here in a little bit, is that we have received recommendations from the Food Safety Standards Board in some potential additional modifications to the agency rule as it is specific to food products that may be considered by the Board of Health at a future board meeting. Okay, so there are a couple areas that I was asked specifically to speak to today. Number one was what were the testing provisions that were in the July 10th, thank you, that were in the July 10th version of the rule. And so those emergency rules, I will point out that the majority of the language that was proposed in that July 10th version came from the state of Oregon. So the state of Oregon has called together a consortium of many other states as well as industry experts and really grappling with what could be best practices and some standardized standards for testing requirements for medical marijuana. So here you have links to two of the Oregon reports that are fairly comprehensive. And so you'll find that a lot of the language that was in the July 10th version did try to mirror that language in Oregon. Now, I will point out that there were some portions of that July 10th rule, some smaller portions that did come from California rule language. Now, we certainly received some strong caution from the industry that California was not necessarily a model that Oklahoma should be taking a look at. From what I understand, California's model was viewed as being unsustainable. It was not fully implemented, and I guess at current date, California is actually looking to roll back some of their regulations. So we appreciated that input, and so it's certainly something that we're trying to identify those parts of that rule that were California specific. There were some major categories. So what I'm going to go through, rather than kind of going exhaustively through the testing requirements, because in full disclosure, I am not a scientist, I'm not a laboratory expert, I'm a policy person. And so what I'm going to speak to you today about and provide just some overview of what the major components of the policy were to try to get a working understanding of how July 10th's rules compare and contrast to what you'll see in the Food Safety Standards Board rules. Okay, so there are definitions that are included with any laboratory, defining what is an approved lab, what an accreditation or an approval process looks like for a laboratory to be able to be qualified to test a medical marijuana product. You'll see at the bottom of this slide there are references to the NELAC Institute, the ANSI and the ASQ, National Accreditation Board, and other similar accrediting entities using ISO and IEC standards. So whenever I talk to folks that are much more knowledgeable than I am about those scientific standards, those are general nationally accepted accrediting standards for any laboratory, not just specific to medical marijuana, but many laboratories that are currently in place in the state, let's say for environmental assessments and analyses. These are the types of accrediting bodies that when a lab receives that accreditation, that is a recognition that that laboratory has met the mark for the qualifications. Okay, the testing provisions in the July 10th rule, there were certain testing requirements for growers. So as you think about growers, processors, and dispensaries, so from the field being the growers, the processors, which is where there are that is where the concentrating, that's where the raw material is transformed into some other usable product. That's what we're talking about for processors. And then dispensaries being the retail outlets, right? So if you think about from field to actual product consumption, we recognize that there could be testing at any given point in that process. But specifically, the July 10th rules did have testing requirements for growers, and then processors and dispensaries would be prohibited from accepting untested products. So you see how if the grower is responsible for the test, when their product gets transferred over to a processor and then to a dispensary, that processor or dispensary could use the test results of the grower to make sure that that product is safe across the continuum. So what is it that we're testing for? So let's go through the list of the requirements for the testing categories as of the July 10th version. Cannabinoids, so different types of chemical that are and the substances that are actually in the medical marijuana. Residual pesticides, so of course, if you're talking about an agricultural grow and if there were pesticides used, we want to make sure that that's not coming over to the product. Heavy metals, microbiological impurities, residual solvents and processing chemicals. So by nature of a processor trying to manipulate the raw form into a concentrate or into some other form, there may be chemicals used in that process. We want to make sure it's not coming over into the product. Water activity and moisture content. This is primarily related to the microbiological impurities, right? So in order for something organic to grow, it oftentimes requires water. So that's why water activity is included on there. Foreign materials, so this is contaminants, filth, things that inadvertently get into the product through the process. Sterility, which this was something that we were subsequently advised that it really requires samples to be collected, stored for a long period of time, and then retested, right? So that's something that I think was specific to a California aspect of the testing requirements that may be in question for Oklahoma to consider if that's something that may continue to be of value. And then such other testing categories as the department may identify. And the department did not identify, as of the July 10th version, any other categories that we would be interested in. For those of you that might be wanting to look specifically at the list of the scientific names of each one of the elements, as well as the testing thresholds, the July 10th version of rule did contain an appendix that had detailed tables that would list out all of those details on what was actually included in each one of those categories. So we're still on the July 10th version of the rules. Again, these are not currently in effect. Those were since modified. But other categories of that rule did require requirements for testing certain types of medical marijuana. So it was usable marijuana, concentrates and extracts, cannabinoid products, as well as random testing, kind of in a quality control type environment. There were certain requirements for the sampling, so batch samples and standard operating procedures to be able to collect those batches, as well as the collection, how those would be transported, the size of the sample. And I will say that anytime you're talking about a business that is looking at a cash crop, if you will, we did receive some comments on the size of those samples would, of course, be of interest to the business community. We want to make sure we're not taking a significant portion of a harvest for testing purposes, right? So there has to be that happy medium found where the sample is of course enough sample to be able to determine a relevant test result, but something that is not creating a business hardship for taking product out of the sales line. Okay, so July 10th version of the rule, there was quite a bit in there, right? It was subchapter 8 of the rule in July 10th. As you can see through the summarized list that I just went through, there was quite a bit in those testing requirements. I'd be remiss if I didn't comment that we had received public comments on testing specifically. And so we did receive about over 1,000 comments during our about 10-day public comment period. About 10 to 15 of those were specific to laboratory testing, and they really got very, very specific, right? They were coming from kind of a scientific perspective and really provided a wealth of knowledge to the health department to consider. We also had a little fewer than 5 private laboratories that expressed interest in learning more about what the standards would be, because they were expressing interest about operating and becoming a qualified laboratory in Oklahoma to be able to provide that service to the newfound industry. So the major areas of input that we found on testing were laboratory selection and approval. So recognizing that there's no current state process of selecting medical marijuana labs, there is no state lab that is today readily available to be able to test medical marijuana products. As I mentioned, we do have several private labs with interest, but any laboratory that's going to be test medical marijuana is going to have to register with OBN, right? Since it is a Schedule I substance, there is that additional registration requirement. If a state lab were to be pursued, I'll just mention this, whatever agency might host that state lab, it would likely require the promulgation of rules for that agency to be able to incorporate medical marijuana as one of the business lines, and there would more than likely have to be the development of fees associated with providing that testing service. We also received some comments on the accreditation and certification bodies, so again, had references back to the national accrediting standards. We had comments on the cannabis product testing on what types of products should be tested. And so comments ranged from flour to edibles to concentrates, that any product that was going to be used should be subject to testing, or at least the ingredients that go into that product should be subject to testing. The frequency and the comprehensiveness of testing was a key consideration. So as I mentioned before, whenever you talk about sampling, is it a percentage of a batch? Is it a finite weight? There were quite a few comments about making sure that we were being mindful of not just asking for 10 pounds of a substance, for instance, whenever that would be a significant proportion of a specific harvest. We also had comments about detectable amounts. So whenever you're talking about microbiological impurities or pesticides, residue, solvents, things of that nature, we recognize that there may be threshold levels that are either detect or non-detect, right? So the testing standards, the comments that we had said that the testing standards needed to make sure that they were addressing not only what those thresholds were, but to identify what was considered a non-detect amount from a positive detect in any given batch. We received quite a few comments on the potential costs for commercial entities. So this is an area where the health department has not been able to produce some really solid research on what the potential costs are to businesses for various lines of testing. There is a lot of variation when you look at other states on what testing costs that would be borne by the industry may be. So as we look at Oklahoma's market, there's a lot of uncertainty. There needs to be engagement of the labs to be able to have that conversation to determine what those potential costs would be. And I would also like to mention that outside of our official public comment period, we did have a meeting at the end of July with several members of our industry advocates. I believe Chip Paul kind of led the lead on that from Oklahomans for Health, where they had submitted to the health department some revised rules that specific to testing that tended to mirror the Illinois model. So that was something that without the health department having that statutory authority to be able to incorporate that into an August 1st rules version. We did appreciate that input, and it certainly gave us something to be able to work with as we're looking at various other state models and trying to make a recommendation on a course forward. Okay, so that gets us through public comments that were received on testing. I'll turn now to the testing provisions that are in the currently promulgated rules that were taken up by the Board of Health on August 1st. These are the rules, as I mentioned, that are currently in effect. The revised emergency rules did remove altogether subchapter 8, which spoke to laboratory testing. So there are no rules that are currently in effect that would require or that would govern the processes over laboratory testing of medical marijuana products. Also removed altogether from that August 1st version were recall procedures for commercial entities. What we have to recognize is that in the August 1st version of the rule, there is no state regulatory requirement for testing or for recall. However, we have heard from members of the industry that that certainly is something that businesses, as they are developing good business practices, may be doing voluntarily to ensure to their customers and to their clientele that they do have a safe product. But from a regulatory standpoint, health department does not have a rule that requires such. There were also clarification of certain definitions. So the definition of an approved laboratory, since subchapter 8 regarding labs went away altogether. The definition of an approved laboratory also went away. However, August 1st version of the rule did retain the product labeling requirements, advising of risk to children and to pregnant women. Okay, so that is it as far as the currently promulgated rules that were adopted on August 1st. What I'd like to speak to a little bit now is the Food Safety Standards Board. FSSB is the acronym that you'll see on this slide deck. And this is the board that was created through State Question 788. As I mentioned, it was a 12-member board that must be established by the State Department of Health to develop food safety standards for medical marijuana processing and handling. So again, limited scope, it's only food, and it is specific to processing and handling medical marijuana. So whenever we look at the clarifications that were made in the August 1st version of the rule specific to the Food Safety Standards Board, we wanted to make sure that it had adequate representation from knowledgeable experts. So we had some changes in the selection of the qualified candidates. It also, one of the changes was to incorporate public health representation on that board, as well as clarified that the deadline for that board to make its initial recommendation to the Board of Health was 60 days after passage of the state question. And so for us, it was August 27th, that first Monday that met that 60-day timeline. What I'd like to point out, because I did alert members of our Food Safety Standards Board that I would be offering some remarks on their work, and that I did not want to speak to their intent, but rather be able to speak to their to the facts of what it was that they passed. But I did want to point out that we do have some Food Safety Standard Board members here in the room that if you have follow-up questions for them specifically, they may be able to speak to those. We have Scott Yates from Department of Agriculture, Scott Schaefer from the Oklahoma Poison Center, Fenton Rood from Oklahoma Department of Environmental Quality, Bud Scott from New Health Solutions Oklahoma, and Troy Scow from the Oklahoma City County Health Department. I think that's everyone that I saw, unless someone snuck in on me after we started. So thank you very much, board members, for being here. So let me take you a little bit through what it was that the Food Safety Standards Board took up in relation to testing provisions. The board did a lot of very quick work, right? So they met for 3 days, August 14th and 15th, and then again on August 24th. The fruits of their labor of those 3-day meetings are available on the OMMA website. So there are meeting minutes as well as recordings of those meetings and their draft regulations and rule revision recommendations. All those are available online. But the Food Safety Standards Board really wrestled with what a potential testing requirement specific to food products could and should be. So they called in experts, number one from FOCUS, that is a national organization. It stands for the Foundation of Cannabis Unified Standards. It's an independent organization. Jeremy Applin and Leslie Engelking came and provided information to that group on what that group had researched in other states and their process of being able to develop testing standards specific to medical marijuana. They heard, I think, a day's worth of presentation from FOCUS, and they were very knowledgeable folks and certainly helped. Then the Food Safety Standards Board also asked specifically for the testing requirements of Illinois, Colorado, Oregon, Washington, Montana, and Michigan. These were states that they felt were similar enough to Oklahoma's makeup that they really wanted to do a side-by-side comparison on what testing requirements were in place in those states, what the thresholds were, and just get a feel for other states that had gone forward with those requirements, what that might be. I believe that the board found that it's somewhat of a potpourri in what is required by other states and where those thresholds are. So the board, where they ended up with their recommendations, was really fine, right? So whenever you have some states that have very aggressive testing standards and then perhaps some that are more on the looser end, they shot for something that was in the middle. And the Food Safety Standards Board largely came to the conclusion that the state of Colorado, for them, tended to have a midpoint. So what you will see in the recommendations that are put forth by the Food Safety Standards Board specific to food products is that largely they're looking at the state of Colorado and the rules and the testing requirements that are currently in existence there. In these draft rules, and I will say that in your handouts, you all also have a copy of the draft recommended rule revisions that have not yet been adopted. These are still in draft format. They've not been made official, and they could potentially be considered at a future Board of Health meeting. But I'll take you through just a few of the highlights from their work. It did establish a new rule section, which is section 681-5-8.1, which did establish certain requirements for food safety standards specific to processors. So again, I did mention that that board has somewhat of a limited purview, so they're talking about testing standards only for processors. And then the standards also relate to only those items that meet the definition of food. One of the important recommendations that the board put forth is that licensed processors who are dealing with food products that contain medical marijuana, by nature of their products containing medical marijuana, that does not exempt those processors from any other food establishment regulations, right? So just as we may have food manufacturers creating a product or retail establishments that are selling food today, those establishments have to be licensed and have to meet the regulations that are inherent with providing a food product to the public. And so nothing by nature of a medical marijuana product or a product containing medical marijuana would otherwise exempt establishments from those existing requirements. Okay, as the Food Safety Standards Board was taking a look at and really considering what the public, right, what a consumer would want to know about a product that they were getting ready to ingest, they did also add an additional component that would require testing for potency and for the labels of those products to include an indication of what level of THC was included in those products. Now, let me be clear. This is not a limit on trying to say only up to a certain percentage is allowable. This is merely an informational item to the public to let the public know who's getting ready to consume that product what level of THC is in it. There were also requirements for private homes and living or sleeping quarters. There's current rule for any other food establishment that says if you have a food establishment, you cannot, there are certain restrictions on how close and what proximity to your personal sleeping and living quarters that may be. They wanted to make sure that also applied to processors for medical marijuana. Lastly, the requirements for processors to conduct testing procedures on those food products containing medical marijuana. So we want to make sure there are standard operating procedures on the ways those tests are performed. Okay, so lastly, with the Food Safety Standards Board, you will notice on at the bottom of this slide, there was a few differences. There were a few differences from the July 10th list of the potential elements that would need to be tested for and reported on. So those elements that the Food Safety Standards Board felt were most important included microbiological testing, solvent and chemical residue, metals, pesticide residue, potency, and contaminants and filth. So those are the areas that in relation to food products, that the board recommended there be testing for. They also established thresholds, so certain levels at which, underneath which would be acceptable, but over which would require a recall procedure to be triggered, and we would want to make sure that that contaminated product was taken out of the market. If you'd like to see, again, the specific chemicals and the scientific names of what is actually included in each one of those, if you'll go to those draft recommended rules, you will be able to see under each category exactly which chemicals or which substances we're talking about. Like, for example, under solvent and chemical residue, they have things like acetone, benzene, butanes, hexane, isopropyl alcohol, things like that. You could see that detail in there. Okay, so last for me, I think as the health department has worked with our stakeholders, as we've worked with the Food Safety Standards Board, we've heard and we have acknowledged that there are several areas of potential impact. I'm here today to tell you that we, as the State Department of Health, do not yet have all the answers. There are still questions that remain. So what I've tried to indicate for you kind of in this closing slide is things that we believe are known and things that are still that really need some further exploration. So considerations for laboratory testing as the state moves forward should, of course, consider other states' occurrences of adverse events and negative experience that are resulting from adulterated products. So has there been impact on the public due to bad batches or contaminated or adulterated products? Also to consider are other state approaches to testing, if the testing is required versus is it voluntary. They should also, we should consider in-state laboratory availability. So products containing THC should not move across state lines. So we really look at needing to have facilities in Oklahoma that can provide that service to the industry. Need to take a look at current state and private laboratory capacity and the time frames for the laboratories to be able to conduct medical marijuana testing. As I mentioned before, that currently there is no state lab that is fully equipped today to begin testing medical marijuana products. Now we have heard from several private labs that are actively working on being able to receive those registrations from OBN to be able to test the products, but it is a growing business line in the current labs that are in the state. We also need to consider the state role in laboratory accreditation and/or approval. So does the state want to use a national standard? Does the state want to use a state standard? Does the state want to employ a state-run laboratory? I think there are examples of each one of these in other states, and I think there is a hefty list of pros and cons associated with each. Then lastly, as I mentioned earlier, the cost implications for businesses. That's something that we have heard from the public at large, that we need to know going forward what is an affirmative cost for the testing elements that potentially could be required of the business industry. And with that, I'll make one plug for the OMMA website is collecting applications, and as well we do have a call center. The number to the call center is here on the screen, 522-OMMA. So for any of you who may have constituents who have questions, it is up and running 8:30 to 5 Monday through Friday.
Thank you very much, Ms. Heater. I'd like to go ahead and allow the committee to ask questions. If you'd like to take them from your seat, that'd be fine. You can take them from the podium, but I'm guessing you'd like to go sit down now. All right. Questions from the committee for the Department of Health? Senator Yak.
Thank you, Mr. Chairman. Thank you, Ms. Heater, for being here today. So I think this is maybe a reference to slide 15. You mentioned some states are more aggressive. What did you mean by that term, just as far as the requirements in the testing, or some are protecting the public more than others?
Right. So there's two ways, I think, generally speaking, that we could talk about it being more aggressive. One would be just the number of substances or of chemicals that have to be tested for. So if you could have a list that perhaps only had 6 mandatory tested substances, whereas other states may have a list of 18 testing substances. So whenever I say aggressive, if there is a wider variety of substances that are being tested for, that's one way that I'm speaking about it. The other way is the threshold limits. So whenever you think about a parts per million, right? So let's say, for example, butane, in a parts per million. Some states may set that as the acceptable threshold is 5 parts per million, and under would be acceptable. Whereas other states may set that threshold at 1 part per million, which would be a much lower concentration. So whenever I say aggressive, states that either have more varied or a larger list of substances that are tested, as well as states that may have tighter constraints on the amount of available contaminant, for lack of a better word. That's what I'm referring to whenever I say aggressive.
Follow up.
So it'd be fair to say that more aggressive states or states that require more aggressive testing have more concern with public health or public safety?
So yes, I think generally speaking, that would, they are wanting to ensure that they know exactly what is in that product and what's going out to the public.
Follow up.
Last one. Thank you, Mr. Chairman. So when it comes to labeling those states, and I think you said they settled on some of the Colorado rules, so is the labeling going to show that that product's been approved by a testing laboratory? Does that show up on their labeling?
So labeling is something that is not necessarily required by or provided by a lab, but rather on the commercial entity themselves. They have to ensure that the design and the layout of their labels that they are putting on those packages contain the mandatory elements and are easily viewable to the public.
Representative Copeland.
Thank you, Mr. Chairman. My question is pretty simple. Will 788 be implemented by the Department of Health absent any legislative action dealing with testing?
Yes, because we are currently accepting applications and are processing licenses, and that includes businesses. So business entities are receiving their applications or their licenses.
Follow up.
Thank you, Mr. Chairman. So absent any legislative action, and according to your slide, the only option you have is to have a voluntary testing program until action is taken to set up some testing mechanism, correct?
That is correct, with the only exception being should the draft rules be promulgated by the Food Safety Standards Board, there would be testing requirements for processors specific to food products.
Follow up.
Thank you, Mr. Chairman. So what you're saying is that any edible can be, a system can be set up to test that by this board, but that's the only testing that you have the authority as the Department of Health to implement, correct?
That's correct.
One follow-up, please.
Follow up.
Thank you, Mr. Chairman. This will be my last. Okay, you mentioned the voluntary issue, that the state can determine either mandatory or voluntary. What state or what entity has a voluntary system in place today?
To tell you definitively, I would need to go back to my notes to be able to see exactly which state that was. Which one? Arizona, to our Food Safety Standards Board member, Bud Scott, who I think I failed to introduce earlier, so apologies, Bud.
Okay, thank you, Mr. Chairman.
I have some questions from the chair for you. They're much more basic. I've read the definition of food. I would sure love for you to try to put that into a little more plain English if you can, because I could make this definition of food meet anything that I wanted it to, I believe. So what is the definition of food that the Food Safety Standards Board's working off of?
So food, and I'll read it to the group, to those that do not have it in front of them. So food has the same meaning that is set forth in current statute and rule, but it means articles used for food or drink for man, chewing gum, and articles used for components of any such article. Food means any raw, cooked, or processed edible substance, ice, beverage, or ingredient used or intended for use or sale in whole or in part for human consumption. So I think the layman's terms there is the food product is used for human consumption. And so it's not only a food product that is in and of itself, you know, say an apple, right, in its raw form. But if you cut up that apple and put it into a pie or into a cake or into a smoothie, that apple is food product no matter how it is processed. So that's where the language of that definition is trying to make sure that it's clear that we aren't just talking about raw or cooked substances, right? We're talking about any element that makes it into the food product that is for consumption by humans.
Okay, so if I want to smoke marijuana No testing.
Not a food.
Okay, it gets a little fuzzier for me if I want to vape marijuana, because that's, I believe, processed. It's a liquid I could drink if I wanted to, I guess. So will vaping products be tested?
Right, so no, because vaping is considered an inhalation. So we had the same discussion at the Food Safety Standards Board. So, things that are inhaled are not considered food by the definition, so it does require that consumption of the product.
Okay. And I'll.
Whenever the committee's done.
Okay, I have one more and then we'll go to my co-chair. So on slide 17, you go through a list of testing categories, things that would be tested for. So I guess, correct me if I'm wrong, I'm trying to get my head around where we are. If you take marijuana, you turn it into a gummy, then we're going to know, assuming these actually are passed by the board and become law. Right now, these are just out there floating around. But if these were passed, gummies, we would know for sure that if I'm going to ingest a gummy, that it's not going to have pesticide residue, it's not going to have contaminants and filth. We would know those things for sure for gummies and whatever other food products there are. This is out of my wheelhouse for sure. Mm-hmm. So that's correct.
That's right.
Okay. So I guess my question is, if you find a batch of food that has pesticide, contaminants, filth, whatever it may be, I mean, those pesticides, that filth, that would have come from a batch of actual grown marijuana plants. I mean, that's where it all begins. So can you, in this system, if it were to pass, can you track back to the bad batch of marijuana and track back to the farm that's producing marijuana with too much pesticide, too much whatever it may be?
So the short answer is yes. To clarify, though, when we're doing the testing, yes, you're going to have ingredients, right? So medical marijuana ingredients that are going into products, and those may have contaminants, right, as they're put into the process. However, just in the simple food manufacturing process itself, there may be other opportunities absent the medical marijuana to say, an egg's left out on the counter and that ends up in the cookie, and that cookie also contains medical marijuana. So there are other sources than just the medical marijuana that could introduce these types of contaminants. But to answer your question, yes, there is tracking. So one of the definitions that were included in the Food Safety Standards Board is that there would be a lot and that there would be a batch identified that for purposes of being able to track that, numbers would be identified so that they would be able to source to where that product came from, to be able to assist with a recall, to know exactly what batch included that contaminated substance or was the bad batch, and would help that facility then be able to reach out to the consumers who had purchased out of that batch as part of that recall process.
All right, thank you. Representative Eccles.
Thank you, Mr. Co-Chairman. Quick question. We've said a couple things. I just want to make sure we haven't said something so often that's true that it may or may not be. So I'm looking at the July 18th, 2018 letter from the Attorney General. What was the request the Department of Health made in order to receive that letter from the Attorney General?
That may be something I'm going to look to our Nicole Nash, who is our legal counsel.
And I'll let you know, I'm not going anywhere. I'm assuming what happened, I've been told what happened, is you asked the AG to review the rules and then give you some guidance. But is that what happened, or did something else happen?
So what I'm aware of is, I think, what is out there publicly, which is that there were 2 lawsuits that were filed after the July 10th rules were promulgated. And in light of those lawsuits, the commissioner requested that the Attorney General review the rules and the merits of those lawsuits and the recommendations that received, or the guidance we received from the Attorney General is what followed.
Okay, and for a follow-up? So the request, just to be clear, was to review all of the rules, not just sections of the rules, but to review all of the rules. Is that right?
I don't believe there was a specific language directed that way in the request, but I imagine that a review of all of the rules in light of the legalities at issue in the lawsuit was required.
For a follow-up? So when I review this letter, it certainly looks from the first paragraph like the Attorney General reviewed all of the rules. I don't know what the request was. And he lists 7 specific rules that the board didn't, that he thought the board didn't, or his office thought the board didn't have the authority to do. I've got those written out. Would you agree that none of those 7 specific rules have anything to do with testing?
My recollection is that no, they do not do with testing. And the lawsuits, I believe, did not delve into the testing.
So what I'm trying to figure out is, and this is the old trial lawyer in me, you know, it's an old trick. When I did family law, there was a really good attorney here in town that he would just say stuff over and over at hearing after hearing after hearing after hearing, and by the time we got to the trial, everybody believed something that wasn't true, and it was a really good trick. It worked well. We keep saying the Department of Health doesn't have the authority to promulgate rules on testing, but would you agree we don't have an AG opinion that says that, and the letter from July 18th, 2018 certainly doesn't say that?
Yeah, I would agree. But I think our approach and kind of the direction that we understood we were receiving is that we needed to take kind of a stricter approach and really follow the state question language and the authority that it gave us and recognize where our authority was limited.
For a follow-up? So I like that. I mean, I like going with the language. Anyone's heard me talk. I do think that the citizens tell us what the language should be, and that's it. However, you included a labeling section, which I firmly agree you have the authority to do that. See, part of that is the citizens said the Department of Health is who's going to regulate this industry. That wasn't the choice of the legislature. That was in 788, respecting 788. And you included that labeling section, in my opinion, correctly. Nothing about labeling in 788. So would you at least agree with me that none of the lawsuits had an issue with the testing provisions, that your ability to do the testing provisions, that the AG didn't issue a letter saying you can't promulgate testing rules, and that whether or not you have the legal authority to promulgate testing rules at best is at doubt, that it's possible that you do?
That is correct.
Okay. With that in mind, why did the board decide to strike all testing provisions from its second set of emergency rules?
I think that, as I stated earlier, we really understood that the direction to us was we needed to take a strict approach and follow the language. And the language of the state question doesn't provide for testing, doesn't address laboratories, doesn't give us the ability to approve or license laboratories. And so with all of that, taking a strict approach, we did not see that we had the authority. Any authority that we believe does rest there seems to lie with the Food Safety Standards Board.
And I'm going to let you off the hook because this is an unfair question, but obviously that same argument would apply to labeling, but the board found they had the authority to do labeling. And that's an unfair, mean question, but we're in a public setting, so I want to make sure I made kind of my point. Yeah. So I'm not trying to put you on the spot with that.
No, I understand. I think that there are some things that, this was put in the purview of the health department, and our foremost consideration has to be the public health and safety, and we felt so strongly that those needed to stay in. Also taking into effect that our understanding is, like as Buffy said earlier, there is nothing in the state question that relieves food establishments and food manufacturers from their current labeling and manufacturing obligations under existing food safety laws. And so those apply as well and are under our purview.
Well, and for a follow-up, and I appreciate that, but to be clear on the labeling standards, you didn't just label food products. You labeled, and I quote, 681-7-1 subsection 3, all medical marijuana and medical marijuana products. And by the way, I'm commending you for this. I'm really excited you did this. This is the section where you said that you cannot package labeling medical marijuana that's attractive to minors and things like that. But just to be clear, because it gets confusing in here, the labeling does apply to all medical marijuana products, correct?
Yes.
My final follow-up? Sure. Given that we agree that at a bare minimum, there's no express prohibition. By the way, I think you do have the authority to do testing. I think it could not be more clear. I think your enabling language couldn't make it more clear. I don't understand. I think if the AG didn't thought you have the ability to regulate testing, he would have said so, because he was perfectly capable, his office was perfectly capable of doing that. I think there is almost no way that the commissioner asked for anything other than a full review of the rules. I mean, anything else would have just, I can't fathom why someone would do that, you know, if there's another problem. And no one, honestly, no one objected, even in the lawsuits. Would the Department of Health be open to a conversation if some testing protocols could be agreed to? Now, I'm making a huge wide stretch on this, okay? So assume for a second we can have some testing protocols that we think would be acceptable and in the best interest of the citizens of the state of Oklahoma. Would the Department of Health be open to having a conversation about implementing those protocols?
Yes.
That was an easy one. I put enough caveats in there. You can't be nailed down to anything, and that was the purpose. I appreciate you coming today, and I have no further questions.
Senator Daniels.
Thank you, Mr. Chairman. So just as we are on the verge of creating all sorts of new business opportunities for people involved with medical marijuana, you bring up the question of laboratories. And we have a limited number, but this is another, market possibility for private labs. Is there anything in other states that require all the testing be done in a state-owned lab? And is there any reason, in your opinion, that that would be a requirement in Oklahoma?
So I am aware of instances where there is a state-run lab. I can't tell you exactly the state as of right now, but I know that that is one of the options that is available. Whenever you're talking about a state-run lab, I think the major consideration is the time frame for the state to be able to make that business service available to the industry. We've heard that that may be 18 months to 2 years to be able to develop that. We also recognize by nature of it being a state entity, rule promulgation, establishment of fees, things like that, it gets a little bit more complex whenever you're talking about a state-run entity. So I think that's a consideration. As I mentioned in my presentation, there are pros and cons to each one of those. Allowing private labs to be able to provide that service versus or perhaps in addition to a state lab. That's certainly something the state should consider, but I think there may be time frame and cost considerations for the state that really just need to be fully explored.
Representative West.
Thank you, Mr. Chairman. So we talked about product testing and recall, and in some ways that's kind of the end of the process that we've talked about. Shouldn't there be, or would you agree, there should be safety standards and processes that should be in place from the beginning to prevent these problems, the problems to start with, to avoid the recall?
Right. So yes, right. And whenever we look at there's existing bodies of regulation that pertain to, to go back to the example of food products, right? There are already regulations in place that are intended to be able to make sure that that safe plans and processes are in use at manufacturers of food. So I think as the state thinks about laboratory testing, yes, it is a kind of an in-product test and a result that you receive. However, that should inform that business's processes up the stream of manufacturing and of distribution to ensure that they're going to get a good test at the downstream result. You know, what they're really talking about from the business community, they are going to be inclined to be able to make sure that those upstream processes are tight, because if they suffer a recall, that's going to be taking their product out of the market. So that's in essence a 100% business loss, right? If you have a recall, you're pulling all that back, and then the business industry is responsible for destroying that product, right? So it's in the best interest of the business to be able to have those processes up front, because no one wants to have a recall that's going to mean that business is losing money due to a destroyed product line.
Okay, thank you.
More questions from the chair? Just to follow on my co-chair's line, I guess the main question is, when does the Board of Health meet next? And do they plan on taking up the Food Safety Board's recommendations at that meeting?
So to my knowledge, that has not been determined and solidified as of yet. The next meeting of the Board of Health is September 14th. So that would be the earliest opportunity for them to be able to take up those recommendations. I have not yet seen that final agenda, so I do not know if that is planned at that specific meeting.
How often does the Board of Health meet? So after September 14th, when is that the next meeting, if you know that off the top of your head?
Right, so they typically meet monthly, but as
Okay.
we go into the fall months, it is not every single month. So I believe we have September 14th. There is what's known as a tri-board meeting that I believe occurs in October, which is a little different. It's not a typical Board of Health meeting where it's a meeting of the other city, county health departments. So it's a little bit different. And then there is another meeting in December, I believe, that is a regularly scheduled Board of Health meeting.
Okay. One more from me, and then we'll get to Senator Yak. So basically, going back to the original testimony, that we're going to have some potential for unsafe products to be out on the market because we're not testing them, not necessarily edibles, but any other type of marijuana. Does the Department of Health plan to do any form of public education campaign, letting those consumers know that the products that they are going to be smoking, vaping, whatever they're going to be doing, may or may not be safe, and that it's buyer beware type mentality at this point?
Right. So we are in the early stages of development of an informational one-pager that would be made available on the website that does speak to what the requirements are for the product and where those requirements perhaps fall short, so that the consumers can know the right questions to ask the businesses that they're going to obtain their products from, as a guide on what consumers should be asking of the business establishments that are providing that product.
Thank you. Senator Yak.
Thank you, Mr. Chairman. I thought of something. When it comes to self-grow, I don't think you talked about that in your presentation, so I assume in the other states that allow self-grow, and I think there are others that allow for self-grow, that part of the medicine that's produced goes untested. Is that right?
That's right. I don't believe there was anything in the July 10th version, the prior version of the rule, that included any provisions for testing of home grow. There was. Go ahead.
So the prior rules, the July 10th version, did have some specific requirements for when a patient would take their home grow to a processor to be concentrated. And then in that situation, the same testing requirements would apply to that concentrate that's being made for the patient, but otherwise there was no testing.
Representative West.
Do you know if there's a current process for licensing labs that are authorized to commercially test Schedule I narcotics in this way?
So I'm going to answer simply and say yes. I do not know the details of those requirements. That may be something that, well, I'd hate to put him on the spot, but I know we have representation from our Food Safety Standards Board. I may ask if, because I believe the Department of Environmental Quality currently has some accrediting standards for labs across the state. If that was something, again, hey, Fenton, if perhaps you would like to speak to that. Yeah, so the answer is yes, but details of those would need to come from a more knowledgeable expert.
Senator Paxton?
Mr. Chairman, I'm going to go back to the home grow issue. If somebody has a private water well, they don't have to get it tested, but most of us who do have that choose to have it tested. There's places that have it tested. If somebody is home growing their medicine and they want to go have it tested, are there going to be places where they can go do that?
So that's if the laboratory industry responds and makes that business line available, then that answer would be yes. Okay. But that would likely be through private labs.
Okay, thank you.
Seeing no other questions, I think this would be a great time to take a 10-minute break, and then we'll move on to our next presenter. I'm sorry, Representative Copeland. Sorry, I nodded at you and everything. I wrote your name down, and sorry.
Mr. Chairman, I'm easily ignored, so that's all right. I understand. The question arose when you talked about the one state that was thinking about doing testing and you didn't name it. And I had an individual approach me and say that the State Department of Ag had the ability to do this testing. And the question arose as to whether if they did the testing, they might lose federal funding because of some of the federal laws we have, or the federal laws against cannabis. So is there a concern if there's any type of state entity that does the testing that federal funding is at risk with that entity, or is it possible for a state-run agency to do this testing in some way, shape, or fashion?
So it's my understanding that the registration with OBN is what provides that cover, so to speak, to be able to deal with Schedule I substances. So that's why any laboratory, prior to them being able to engage in the product testing, would have to seek and secure that OBN registration. I can't speak directly to your question about Department of Ag, but I will say that one of our Food Safety Standards Board representatives was from Ag. And again, I'm putting all kinds of folks on the spot today. So Scott's shaking his head, saying no, doesn't have any information to be able to provide on that to be able to confirm that. So unfortunately, can't speak to it.
All right, making sure I didn't forget anyone else. Wave now or forever hold your peace. Thank you guys very much for being here. Thank you for your presentation, and we will take a 10-minute break. We will be back at 10, well, we'll call it a 9-minute break, so 10:25. I'd like to go into the second presentation of the morning. If you're looking at the agenda, basically what we will do here is we'll have one more presentation, and then we will open it up for questions not only from the presenter, but from the other groups that are on the agenda. They came to answer questions, not to make presentations. Many of them we've already heard their presentations, many of them more than once. But they will be here to answer questions. So with that, we will move on to Dr. Lawrence Pasternak. Came close to getting that right, I hope. Pasternak. In southeastern Oklahoma, it's Pasternak. But the floor is yours. Thank you very much for being here and bringing the presentation.
One quick question just in terms of how to use this. My name is Lawrence Pasternak. That's at least how I pronounce it. I'm a professor at Oklahoma State University, but today I'm certainly speaking just as a citizen of the state of Oklahoma. I've been involved in the medical marijuana movement really not especially long, 8 months, give or take. I just became curious, thought it was important, decided to educate myself. And among the things that I have explored over this time is what consumers need, what patients need. As a medical product, one would expect some kind of consistency, one would expect predictability, and one would need information to determine what the product is, try to figure out the way in which a product is going to help you if you want to change to a different product, to try to track what you've used, and based upon its effects, to try to figure out what maybe to try next. When we think about product labeling, one could think about, for instance, Benadryl. You go to a pharmacy, you go to a drugstore, you go to Walmart, and on the label of Benadryl, on the label of NyQuil, on the label of a multiplicity of just over-the-counter medications, well, you're going to find a label that lists the various medically active compounds and their concentrations. So my thought is, as a medical product, that should be our goal. Have labels that list those medically active compounds. The challenge, of course, is that we are looking at a plant, and it's much more complex. We're not looking at individual isolated molecules, and there are some very good reasons for thinking about the value, the medical value of marijuana in terms of a whole plant medication, and I will get to this. Some of you might have visited dispensaries, many of you have not. They come in all different shapes and sizes, but typically there is a somewhat controlled area where a patient would enter and look to see what kinds of strains, what sorts of products are available in the store. As you can see, there are typically jars with flour. There are quite a variety of different, there are ointments, there are patches. However, of course, flour is a very common way in which people consume marijuana. So if one were to go into a store, that store might inventory perhaps 5, 10, 15 different strains, and the strains will have names that marijuana consumers are familiar with, Blue Dream, OG Kush, names such as that. The question is, what do they really mean? What do those strains actually mean? They're based upon the genetics of a plant, but really loosely so, because if you were to buy seeds from one business for Blue Dream and buy seeds from another business for Blue Dream, they may not be genetically the same. And likewise, the growing conditions from one grower to another will be very different. And those growing conditions will likewise affect the medically active compounds. So if a patient is interested in finding consistency and predictability, merely a strain name is not especially helpful. When you think about a label for the product, listing the strain name is certainly not enough to provide the information that you need and the predictability that you need. So when you start thinking about what the plant has within it, when you start thinking about its chemical structure and what one can do to try to start determining the medically active compounds, identifying the medically active compounds, just something that may not be familiar to many people is that the plant matter itself, for the most part, is relatively low in those medically active compounds. Almost all of them exist on what are called trichomes on the surface of the plant. So when you look at the close-up, you'll see these, pretty little crystallized, glistening trying to remember the term for it, glands that contain within them both cannabinoids and terpenes. So the medically active compounds within marijuana, for the most part, are in those glands. And they are composed of an array of cannabinoids, many more than just THC, many more than just THC and CBD. They also include an array of other compounds called terpenes, flavonoids, and so on. Now, In the 1970s, 1980s, scientists recognized the effects of THC, and they started to discover that there were other cannabinoids. CBD, of course, is one that's familiar to us, but there are many other cannabinoids that are present, and they all have varying effects, medical effects and psychoactive effects. Just to give you an example, CBD can reduce the psychoactivity of THC. THCV, THC verin, likewise could reduce the psychoactivity of THC. So the ratios between these will have a different effect depending on the ratio. THCV, for instance, even in relatively small quantities, reduces the psychoactivity of THC, but it has a shorter half-life than THC. So the entire pattern of basically the trajectory of psychoactivity is going to vary over time as well relative to all of the individual cannabinoids within the product. This is the kind of information that a patient would want to know. They would want to know when they're going to consume something, what to expect. And that expectation is not reducible just to the THC percentage, and it's not reducible even to the ratio between THC and CBD. In addition to the cannabinoids, there's a whole array of terpenes. And terpenes exist in nature in quite a few other different plants. They're found in lemon rinds, they're found in broccoli, and so on and so forth. They're found, however, in some of them in particularly high concentrations in marijuana, as well as that THC, for reasons that are still being investigated, THC seems to significantly affect the level, alter the effects of these terpenes. They increase the effects of these terpenes, for instance. So, for instance, lavender has within it the terpene called the linalool. And so people will often, for instance, will use aromatherapy. They might have lavender ointments or a lavender spray. And the smell of lavender is supposed to be relaxing for people. So some strains of marijuana have this linalool within it, and that plays a role in its psychoactivity. And it seems as if THC amplifies the effect of these terpenes. So you consume cannabis with linalool in it, you're going to get a different effect than if you consume cannabis with, say, a higher amount of limonene in it. When you start investigating the plant, what you start discovering is that there are complicated combinatory relationships between all of these cannabinoids and all of these terpenes. And so this is often referred to as the entourage effect, that as individual isolates, they work in different ways than how they work in combination. And for the most part, THC as a pure isolate is not particularly a good thing. Just for instance, if it's consumed orally, it gets converted by the liver into another molecule, 11-OH-THC, which is actually more psychoactive. And THC on its own tends to create more anxiety for individuals. Now, that anxiety then gets moderated by other cannabinoids and other terpenes. So one of the main reasons why so many consumers are unhappy with the idea of taking a THC pill is because the side effects for those are far, far worse. In the couple states that limit medical marijuana to something just like pills, Minnesota, for instance, only 0.16% of their population is enrolled in their medical program, in contrast to an average of roughly around 2% in states with medical programs, as much as 3% in some states. So it's not a popular thing. And in fact, in Minnesota, what happens is they only have a $100 fine, I believe, for home grow. It's not technically legal, but they only fine you $100. So basically, most people will simply just grow their own, as opposed to purchase a THC pill, which for most people would be very unpleasant. So the whole plant has a very different effect than THC alone. And with the other cannabinoids and with those terpenes, you will get an array of different profiles. So when you can see here on the entourage effect, you can see that the combination of this array of terpenoids and the various cannabinoids present yield a result. So the consumer might experience, as you can see in this instance, with this particular strain, a level of relaxation, a level of comfort. It's not particularly energizing, it's somewhat inspiring, and so on. And these are the results of medical research that has been done roughly in the last 10 to 15 years about the specific effects of terpenes in their relationship to cannabinoids, so the various combinatory effects of all of these molecules. So you can go from one strain to the next. We can go from one product to the next that contains this array of cannabinoids and terpenes, and you will get different profiles within what's called the entourage effect. Some of them will boost your energy, some of them will sedate you, some of them will inspire you, some of them will calm you. And these are related to those combinations of cannabinoids and terpenes. So when somebody says, marijuana is not predictable, I don't know what it's going to do for me, we don't know really enough about it. Well, in fact, there is a substantial amount of research that's been done drilling down into individual strains and the effects of individual strains, looking at the combinations of their active components, and thereby coming to models such as this as to what the collective effect of one strain versus another strain will have on individuals. So, testing. Here is, I think, a relatively up-to-date map. You know, we have 31 states that have legalized marijuana, and to my knowledge, every state that has legalized marijuana has a testing program in place. And what this testing program will do is they will take samples from a grower, they will process those samples through one form of testing equipment or another, HPLC, gas chromatography, and so forth. And the result basically will be an array of data concerning cannabinoid concentrations and terpene concentrations. Some businesses only test for cannabinoids, some businesses test for cannabinoids and terpenes. When you look at the legislation around the country, to my knowledge, there is no state that requires testing for terpenes. There's cannabinoid testing, certainly, but I don't believe that there's any state that requires terpene testing. And I wonder as to the reason why, and one conjecture that I have as to the reason why is that we model one state that basically joins the other states in legalizing, will be modeling their legislation off of, for instance, California, a state that has had marijuana legal for 22 years. And the science that shaped their legislation was the science of the 1990s. So the increasing understanding of the multiplicity of cannabinoids and how they work together started to arise in the early 2000s. And then in the late 2000s, they started to understand terpenes and their combinatory effects. So to my knowledge, there is no state that requires terpene testing, and I think the reason why is because the legislation basically is based on antiquated science. However, lots of businesses choose to, and one of the reasons why is because the medical consumer wants to know whether or not this product is going to put them to sleep. They're in pain, they wake up, they want to deal with their pain for the day. They don't want to just fall asleep, so they don't want to take a strain that's sedating. If they're taking it at night, they might, but earlier in the day, they might want something that's more energizing. So by having these terpene profiles, a consumer can determine what strain for what need. These are just a bunch of samples of different labels that come from various states. And as you see, they're really very diverse. Some of them provide far less information than others. Some of them for reasons that I'm not going to bore you with now, but for reasons that are sort of a particular interest of mine, some of them show the range of THC. So you see, for instance, for this ghost ship, it's anywhere from 11% to 21% THC. So there's a pro and a con to showing a range of THC levels as opposed to a fixed value. The disadvantage is you say, well, how much is in it? You're kind of concerned. Am I getting something that's 11% or am I getting something that's 21%? You just may not know. But there's an advantage to that as well, because that sends a message to the consumer that they need to, with a particular product that they purchased, figure out if they're inhaling it, for instance, either through smoking or vaporizing. Be cautious. Inhale once, inhale twice, see how it affects you. Give it a couple minutes. And then if you need something, inhale it again. So there's an uncertainty represented on that label that sends, I think, a useful consumer message. However, that range doesn't have to be that broad. That range, to some extent, is due to the sampling techniques that are used. And there's ways to make those sampling techniques more efficient to reduce those ranges significantly. Well, in addition to just listing THC and CBD, which is fairly common, you could see that some of them have much more detailed labels. The one in the top left, for instance, on the left side of it, it has an array of cannabinoid concentrations, and then on the right, it has the array of terpene concentrations. Likewise, middle bottom, similarly, you can see that there's both cannabinoids and terpenes labeled. So quite a few states have, not as a matter of regulation, but as a matter of their culture, their customs, and the expectations of consumers, gone well beyond just listing THC and well beyond listing just THC and CBD, because there's just a lot more to that plant. And a patient who wants to, for instance, relieve pain, relieve muscle spasticity, relieve anxiety, relieve nausea, calling it, hey, try Blue Dream, see if it works. The patient ideally would be educated beyond just saying, here's the strain's name, because as I said, there's little predictability in that. One thing called Blue Dream could be very different than another. But if the product is properly tested and you come to realize something high in myrcene has benefits for you, then you could choose products for yourself that are high in myrcene. And let me add, in addition to that, when we think about what impact a label has on a patient, let's say we only listed THC. Let's say the only thing we listed on a label was THC. Then the consumer might then say, well, that's all that matters. And so I want something better than what I've used. Give me more THC, because that's the only information they have to go on. Well, that may not help them. It might not. If we had a label with a whole array of information, or a handout, some other resource that the consumer can go to look beyond just the THC and to see all the other medically active compounds, then they might discover that a 4% THC with a high linalool concentration is more beneficial to them than a 12% THC. It's going to very much depend upon the individual patient, on their level of tolerance, on their medical needs, and so on. But the more information that we give the consumer, the more guidance they have, the more control they have over making their decisions, and to the extent to which we want people to be using these products medically, we want them to be able to treat their medical conditions with it, having detailed labels provides those patients with an abundance of information that they can start utilizing to associate with the effects of the product and be able to then move to other products based upon what they've observed in their improvements or detriments to their own health through that use. So in my opinion, the more information, the better. The more detailed the label, the better. Here is just a close-up, so you can see how much information some of these have. Here's another one. And sometimes you're going to have something small enough, you may not be able to get all that information onto the product. Well, there's lots of other ways to deal with that. You could have it on the website. There could be a QR code on the product that with our phones, we can just scan it and it'll pop up on our phone screens. Or it could be a printout that goes along with the package. Or it could be printed out as the patient label. It could be just a display in the stores. It could be dropped into the exit bag. There's just lots of ways in which that information can be made available to the consumer. And with that information, what's going to matter to the consumer is more than just THC. And they're going to then be able to get beyond just, hey, Blue Dream, let's see if this helped. It helped last time. Because if they go to a store, another store with Blue Dream, and they look at the label on it, and they discover that the Blue Dream they used last time was very high in myrcene, and the Blue Dream they use this time is not high in myrcene, they might say, maybe that's not what I want to buy. Let me try something else. Let me find, again, a different product that's high in myrcene. That's the kind of information that, in my opinion, consumers need to be able to utilize marijuana for their array of particular medical circumstances. We know some things. We know a fair amount, increasingly more, about the particular combinatory effects of cannabinoids and terpenes. So one could find this data, and this data ultimately is coming out of research, that you will discover, for instance, something that is high in THC, something that is high in CBD, something that has various mixed levels of THC and CBD, tend to be more beneficial for one particular medical condition over another. Likewise with the terpenes. So research has been able to show that, for instance, limonene improves mood. Linalool is sedative. Carotene helps with pain and inflammation. Pinene boosts energy. And on their own, these individual terpenes have to some extent these effects. That's why people use aromatherapy. And some businesses actually scent their air. I don't know if any of you have noticed this, but certain high-end restaurants, casinos, they will scent their air with, for instance, limonene to boost your mood. Because there is that subtle effect that you may not even be conscious of this product. You know, people have cleaning products at home, right? Pine Sol and so on. Well, the makers of Pine Sol wanted to smell in a certain way because it smells good and it has an emotional impact on you. And it seems as if when you add in THC with all of these things, the psychoactive effects, the psychological effects of these terpenes get amplified. I'm not going to tell you about all of this research. Certainly I don't have the time. But as I said before, if you go back to the 1990s, we knew about THC. We knew about CBD. We knew that there were some other compounds, but we didn't know anything about what they did. And it was really right around 2001. The non-cannabinoids in cannabis, in a sense, is where the research on terpenes began. And then 2003, cannabis is more than simply delta-9 tetrahydrocannabinol. That is, it's more than just THC. So it's roughly only about 15 years ago that the scientific community said, aha, it's not just that marijuana is a biological carrier for THC. There's a lot more going on in that plant medically than just that it has THC. So the early 2000s really provided this sort of breakthrough methodologically, conceptually, in starting to recognize the complexity of the plant. And as the years went on, the research increased. And to some extent, this article 2011 by Ethan Russo, Taming THC, Potential Cannabis Synergy and Phytocannabinoid Terpene Entourage Effects. That, in a way, was sort of a key breakthrough article, because it's in that article that Russo started to put the pieces together that were just sort of being poked at for roughly the decade prior. And he started to really being able to explain the interactions between the cannabinoids and the terpenes. And that, 7 years ago, then created a further explosion in subsequent research about terpenes, about the interactions between terpenes and cannabinoids, so that we are no longer in the 1990s, we are no longer in the 2000s. And when one thinks about what kind of labeling and thus what kind of testing is needed for a medical product, we should not be simply looking back to legislation that was crafted based on science from 20 or more years ago. NyQuil, tells us what its active compounds are. It seems that when we're looking at a medical product of any sort, when we're considering medical marijuana, we should do the same. Our labels should include the medically active compounds. Thank you.
Thank you very much for that presentation. Members, we do have a copy of that will be emailed out to you. So a lot of information on those slides, and I very much appreciate it. As we move into questions, I guess before we get started, if you guys could go through and introduce yourselves, who you represent, all of that type of stuff, that way we know who we can direct questions to. We'll, I guess, start with Chip. You've already.
Yeah, so Chip Paul. I'm chairman for Oklahomans for Health.
Warren Johnson with New Horizon LLC. I'm a prospective entrepreneur in the medical marijuana testing industry.
Bud Scott, Executive Director, New Health Solutions, Oklahoma, attorney for over 75 cannabis businesses, including some laboratories.
All right, with that, are there questions? Representative Rosecrans.
Well, thank you all for coming today. It's Dr. Pasternak, is that right? Well, Doctor, thank you very much for informing us. I'm learning so much, and that's kind of my goal on this and just in general about the medicinal effects of marijuana. So that was eye-opening. My question to you is, are you being invited to medical schools to share that information as well?
I should start with my name when I answer, correct? Lawrence Pasternak. Not as of yet. I have actually just been invited to present before a physician's assistant group later this month.
Very good. Follow up, sorry. I'll skip last week and I forget everything. That's excellent. One of the main issues I'm seeing so far is that physicians aren't really open to looking at marijuana as medical just yet, just from having conversations. And that's not everybody, that's not a blanket statement, just I'm having some issues with that when people contact me. Are you hearing the same thing with some of these board-certified physicians that are charged with giving these licenses?
Physicians outside of Oklahoma, I think, are much more open to it. Once again, we're the 31st state that has legalized it, and it's been legal in some states for as long as 22 years. Similarly, Canada has had it legal for about 18 years, and the Canadian equivalent to the FDA, Health Canada, has something in the order of a 150-page physician's guide. So it's much more normalized within medical practice in a lot of other places. There's about 25 countries around the world, likewise, where it's been legalized. And so the medical community worldwide has had much more training and has learned a lot more about cannabis. The physicians in Oklahoma, my personal experience talking with physicians I know, either physicians that treat me or physicians that I'm friendly with, they're very enthusiastic. They're very eager to learn. Some of them have been learning. Some of them, just as part of their own spare time, intellectual curiosity, has been studying just the kinds of works, and I send them things. I have conversations with a number of them, and for instance, I had a conversation recently with Scott Michener, Dr. Scott Michener, who's in Lawton, about cannabis hyperemesis syndrome. And I started to look at the data and came up with a hypothesis and came up with a treatment protocol. So I'm not a physician, I don't have medical training, I'm just a curious person. And so I really think that there's a thirst for knowledge out there, I really do. That may not be the case with the OSMA leadership, but I do think that the rank and file physicians broadly are very interested in looking for more medical opportunities, more ways of treating their patients.
Thank you for that.
Representative Loring.
Thank you, Mr. Chairman. As a practicing attorney, I really appreciate and understand the value of plagiarism and looking at what other states have done and learning from their experience, which it appears that we're doing that to a great extent with the rules that we're coming up with. But a question that I have for anybody that wants to offer their thoughts on this, and Dr. Pasternak, I think, was headed this direction with what he was telling us here. What can we do here in Oklahoma that will make our law better than what the other states have done?
Well, Lawrence Pasternak, if I could answer that, I think that one piece of it is based on my presentation, that my experience is talking to patients in other states, talking to dispensaries in other states, that it's more and more becoming the norm that terpenes are becoming a major part of the conversation between patients and so-called bud tenders. And so not requiring it as a matter of law, we can still hope that the free market will get there. But that might take time. And it might be that some individual stores will outcompete others because patients will want to go there because they have that information. It's hard to say. But still, in my opinion, as a medical product, it seems appropriate that the medical compounds are listed. And I think that one thing that we can do in Oklahoma is make that the standard. And if I may add, the U.S. Pharmacopoeia, the USP, first of all, it included cannabis from 1851 to 1942. Then it was dropped because of being banned in 1937. It's coming back. And I have a draft of the USP entry for cannabis. And I think that if we based our legislation on that, would be wonderful.
Yeah. Chip, Paul, Oklahomans for Health. Exactly to Dr. Pasternak's point, you know, there's a progression of kind of medical understanding that's going to happen with these constituents that he's talking about. And again, we have a company, my wife and I have a company called New Pharma. We live in this world every day. How do plant flavonoids, how do these constituents in plants affect the human body? And is there medicinal benefit and value in them? So is there medicinal benefit and value in curcumin and turmeric, or beta-carotene and black pepper? So when you get down to the details of how medical cannabis works, it's very important to identify these flavonoids and how they synergize and work together, because they all work for different effects. So literally the same strain of cannabis that's grown under different conditions can produce different medical effects. But it's very important that we understand, and you asked a very good question, how do we lead? Well, we lead by exactly what we're doing, right? So we lead by what we decide in this room. We lead by requiring this kind of testing. We lead by not restricting medical conditions. We lead by the ways that we are leading, and will lead, really, in this field. And we're teed up to do that. We really are. So.
Representative Bud Scott, to answer your question, I want to echo Dr. Pasternak really added some, I think, key provisions to the proposals that we've both worked with legislative staff on drafting, that you guys all have a copy of, but also some of the language that was pushed through with the Food Safety Advisory Board. There were components that we included expanding the requirements for testing certain specific terpenes and other elements related to the cannabis plant. So this is something we can have, I think, an industry-leading testing protocol. And this can be done both through rules and statute. But really want to commend Dr. Pasternak for being a solid voice on this issue.
Senator Daniels.
I thought you said another name that began with D, but I'm the only one with a D on this committee. I don't want to be too rhetorical, but having begun as an opponent of 788 because it was so open-ended, and now we're having a discussion today about how it is so open-ended that for the benefit of the patient, we must now go in and constrain the perhaps original intention of 788. We put more restrictions and therefore costs on the businesses who would provide the product, thereby perhaps restricting access. We want the physician to be more involved and more knowledgeable, yet we made the relationship with the physician in 788 cursory at best. So I'm trying to find this midpoint, because for me, 788 was intended to be somewhat self-medicating. And all of this knowledge is something a consumer should want to have and eventually will have. But now to say we need to backtrack and see that all this is available now at a greater cost to the taxpayer, at a greater cost to those doing businesses, seems to me counterintuitive to that language in 788. So just give me some input on that, because I'm looking for this happy medium.
Lawrence Pasternak, I'd like to speak to that. First of all, cost. So to speak, an a la carte test. So let's say, for instance, you were a home grower and you just were curious as to what your plant was producing. You could bring in a sample and it would cost you something in the ballpark of $100 for the cannabinoid profile, and it would cost you something in the ballpark of $50 for the terpene profile. So for an individual single test, it's an added $50. Now, a grower is going to have a contract with a testing lab, and the cost will go down substantially. So the number of samples that will be required to be sent will be obviously a multiplier. But the difference in cost between testing for just the cannabinoids standardly and testing for the terpenes as well is not a substantial difference. When we're talking about, for instance, a batch that might have a retail value of $10,000 or $20,000, then adding in, if you have a number of samples you're testing, a few extra $100, I don't, in my opinion, I'm not an economist, but it doesn't strike me as onerous. The issue with regard to physician-patient relationships, I'd like to speak to that as well. And my thought is, by having a 2-year license, there is this sense in which that's all the physician is needed for, right? All the physician is needed to sign off on the form, and the patient could just be done with them. Well, consider this, for instance. You go in to see your doctor with some routine medical problem. Your doctor recommends that you try an over-the-counter medication, that you change your eating habits, something like that. Your symptoms go away. You may not see your doctor for a couple years. Or likewise, let's say you're on a maintenance medication. I have supraventricular tachycardia. I take verapamil. And so I get a year's worth of refills. And at the end of the year, I might simply phone up and say, could you give me some more refills? And sometimes the doctor does. If he hasn't seen me for a while, maybe I have to come in, but I can sometimes just with a phone call get another year refill. So effectively, I've seen the doctor once for 2 years of medication. So the physician-patient relationship as it is doesn't necessarily involve a ongoing continuous conversation. That's not necessarily a good thing, but that's sort of the state of affairs. Similarly, with insurance, the number of minutes a physician can spend with a patient comes down to 5 minutes at a time. Not the kind of ideal of the country doctor that you see, right, we have a good conversation with. Modern medicine is, and the economy of modern medicine has done a lot of harm to that physician-patient relationship. When it comes to what cannabis offers is, I'm not an MD, I'm not a DO. I learned this in a matter of months. Physicians can as well, and many physicians have. So imagine this scenario. Right now, a lot of the larger physician groups, the commercial, the corporate entities like Warren Clinic and so forth, aren't allowing their physicians to recommend marijuana. This will then take patients out of their existing physician relationships and having to seek a new physician, basically probably just to sign the form and that's it. So to some extent, it's on the burden of the hospital corporations, it's on the burden of the physicians to welcome patients, to agree to sign these forms, and to educate themselves, because I'm pretty good at educating myself. A lot of other people need guidance from another person. And if that physician learned what I've learned more than what I've learned, then the conversation begins. It's not the last conversation when they sign the form. But if that patient has confidence that physician knows enough about cannabis and can give them ongoing guidance, the patient will want that guidance. Patients want to know what they can do with this product. And somebody who's educated on it, they will seek out. So even though statutorily all that's required is that signature for 2 years, that's really not that different from most medications out there. And whether or not patients return to their physician now is on the shoulders of the physician. Will they be a good conversation partner?
I just wanted to add some color in context of your question, specifically to my experience. So I am from Oklahoma, but I was a resident of Washington State when they passed their marijuana, their medical program there. And so I've got people in my network from up and down the supply chain, as well as other ancillary parts of the business as well. And just from my experience and my conversations with them, the testing element is considered compulsory, right? It's considered a cost of doing business. It's not considered or perceived as being onerous in any way, because at the end of the day, that is how we protect public health and safety, which is everybody's priority, especially from a medical perspective. So and to that point, and me personally, especially coming back into this state, looking at this as a possible opportunity. My wife suffers from Crohn's disease. We're on our 3rd GI doctor, right? We had complications that could have taken the life of her and my child. Right? These things the stakes are very high. So when we're talking about the cost of ensuring the safety of these patients and possibly finding breakthroughs in medication that could possibly, I don't know, save my sanity, right? I just think that it's something that I think is, probably not the highest of priority from the pocketbook perspective, right? I think the health and the science needs to be the priority. That's just me personally.
So Chip, Paul, Clements for Health, you asked about, intent and, why we're coming in now, asking for all this physician drill down and all that. It was always envisioned in the law, right? We wrote an activist law, are there issues with it? We've all talked about those ad nauseum, all right? But we wrote an activist law. We didn't write a 30-page law with regulation that we had to circulate as a petition. I mean, that would have been ridiculous to do. So we wrote an umbrella law, and I think we all understand that here in this room. And what we're about now is intending to regulate properly under that law. So to answer your question, the intent was always to define very specifically that doctor-patient relationship. I think, Buffy could testify to the activist, involvement in Department of Health drafts and things like that, and how we really drilled into that, and how complimentary we were of how they defined that relationship. Again, this just needs to be regulated. So that's why we put it at the Department of Health. Are there legal issues here? Do we need changes in the law? I guess, the 57% of people who voted yes for this would probably think not just quite yet, but there certainly will be, what do we need to do on zoning, right? For us to allow as a body, the zoning stuff to continue the way that it is for these cities to really, increase their liability, I think, that's not responsible, right? We need to fix all that. But anyway, we put regulation under the Department of Health for a reason. We expect the Department of Health to properly regulate our law. I think with everything that's happened, they've done a pretty darn good job. But again, what's missing? Well, really the only thing that's missing, and I think we all agree, is testing, right? Testing is what's missing here. Testing is the irresponsible hole that we are leaving as a community in what they've done. So we need to fix that, right? And we probably need to fix this zoning stuff. But I would say the Department of Health has done a pretty good job. And the other thing is, how many drafts of potential, regulation have you all seen? I mean, I would hope that you've seen everything that I've seen. So, are any of those drafts horrible? No. Really? No. They're responsible, consumer safety. So let's, we all have a fiduciary responsibility in here. I'll tell you a quick story. My grandmother worked at the Capitol Library. Her husband was a former president pro tem of the Senate, a gentleman named Homer Paul. My family came to Oklahoma about 6 generations ago. We were led by a lady named Alaticha, who was a Chickasaw lady. But my family's been interwoven in politics and legal and things that have happened in this state for a long time. So when I walk in here to this room, to this building, I mean, I feel like I have a responsibility that goes beyond my personal opinion. I have a fiduciary responsibility to the people that I represent. I have a fiduciary responsibility to the people in Oklahomans for Health. I have a fiduciary responsibility to my wife and my company. I bring all those things in here. But that could differ vastly from my personal opinion. So we all had personal opinions on 788. But that's not what we're here to do, right? So we're here to fix things. So apologies to kind of use your question to hammer home a point. But, right now, we have a medical marijuana program. It's rolled out. There will be people in the next 2 weeks selling seedlings at grows to home patients. Do we need a testing program to go along with it? I would think we do by November when we're selling stuff. So, and I don't think anyone in here would disagree with that. So we need to do something as a community, whether it's you as lawmakers, whether it's you as Department of Health, whether it's us as activists, but we need to be responsible to the public. And that may seem contrary to, in what you're in mind, feels like loose, writing in 788. But I'm telling you as an activist community, as the principal author, we want this properly regulated.
Senator, if I may follow up, I want to say Mr. Paul just expressed everything, I think, very concisely and on point with how we all feel in this community and from professional side of this. Senator, to your point, there's only one state that actually manages a full-blown medical marijuana program that does not require testing. I mean, this is industry standard, and this is for the best interest of our public health. Is there any other form of medicine that we have a regulatory program like this for that does not require testing? I don't think there is. So, I mean, this is something that, as Mr. Johnson here said, we build into our business models. It's something that's expected. However, one of the issues that we still have not clarified is whether licensed laboratories that can test Schedule I narcotics on a commercial basis, if we have a protocol for that. And it's pretty unclear right now. We've been talking with the Bureau of Narcotics about this, with the Department of Health. So there's folks that want to say, sure, we'll just test our own products. Where? There is no licensing process right now. So these are things that we either do by rule or by statute, but we have to identify and prepare that path so our laboratories can be licensed to accept on a commercial testing basis how to test a Schedule I narcotic. We heard from Fenton Rood from the Department of Environmental Quality. They have the ability to test environmental contaminants, heavy metals, pesticides, herbicides, et cetera. But when you're talking about actually handling a Schedule I narcotic, there is no testing facility license in place right now. So this is something we have to authorize.
Representative Rosecrans.
Well, again, thank you for really clarifying all that. It's beating some of my questions down, which is great. A lot of my questions are a little more specific because, I don't know if you all know this, but I'm running for office again and I'm on the doors. And these things come to me from either doctors, patients, or anything else like that. This is one of my last questions. A major issue I've run into is pain management physicians having issues adding medical marijuana along with certain opioids in their existing drug testing regime. This is going to be open for the whole entire panel. Have any of you heard about this as an issue? Please.
Lawrence Pasternak, I'd like to speak to that. Yes, I have. Chris Moe, otherwise known as Uncle Grumpy, has publicly indicated that he is among the individuals who have been terminated from pain management. He had been seeing the same pain management doctor for 14 years. He routinely tested positive for THC, and the pain management doctor didn't have an issue. And then Chris gets the patient license, and he gets terminated. And those stories are spreading around the state. So I contacted the Oklahoma Pain Society, basically the physicians' organization for pain management. They were supposed to contact me yesterday. They didn't. So I do not know whether or not that society is establishing any official position, making any recommendations. But when one looks at what the concerns are, and I've read about this, I've explored whether or not there have been malpractice suits related to it, and I've also explored the medical issues. Now, one thing that I think is commonly thought about marijuana that's not correct is it's often thought that it's a central nervous system depressant, and it's not exactly correct. A concern that physicians have is they don't want to mix opioids and benzodiazepines, for instance, right? Because they're both CNS depressants, and so there could be slow respiration. This could end up possibly being fatal. Marijuana increases respiration, increases blood pressure, increases heart rate. Not to a major extent, but to a modest extent. Now, there are various compounds in the marijuana, myrcene, for instance, that could be more sedative. But THC is both a psychostimulant and a CNS stimulant. So if you were to think that there's an increased risk of fatality through its use, it strikes me that it's probably the opposite. Likewise, when you look at the data in terms of the medical programs around the country, it's about 80% of enrollees in medical marijuana programs are going in for pain management. So it's the overwhelming majority. And why is that? Well, when you look at the reports from patients, you will find that anywhere from 80 to 95% of pain management patients prefer marijuana for that pain management. It may not handle the levels of pain, severe levels of pain, as well as opioids, but for when you're in a moderate amount of pain and you need some relief, and if your only other alternative is an oxycodone, well, you can actually reduce the number, and that's what the data is showing, that patients in these programs reduce their use of opioids because when they have a severe pain flare-up, they might go to the opioid. When they are just in that kind of 4, 5, 6 level of pain that they just need to deal with, they have another option with marijuana. So it reduces overdose rates, it reduces opioid use. The pharmacology of it suggests that certainly there's no known toxicity, no known fatal toxic level for it. And as a mild stimulant, it helps to reduce the risk of opioids. So medically speaking, it should be, out of the park clear that it's beneficial. When it comes to liability, I looked through a number of journals to see whether or not there's any record of malpractice suits, and looked at 3 articles that likewise tried to find whether or not there have been any malpractice suits for pain management physicians treating patients who have medical marijuana cards. They could not find one in any state over decades. That doesn't mean that maybe there's someone lurking there, nobody found it, but 3 different researchers have tried to find it, they could not find it. But there are lawsuits for medical marijuana patients being terminated by their pain management doctors for failing a standard of care.
Follow up. I know some of y'all might want to add to that, but I just want a follow-up question on that. Do you foresee that happening here in Oklahoma, the lawsuits?
I think there's a possibility. I do not know the specifics of state law on the matter, but like I said, it has happened in other states, and I know that there are attorneys taking a close look at the situation.
If anybody else would like to share your views on the first question, which was, you know, if you have heard about the problems with pain management physicians not wanting to kind of add marijuana to their testing regime.
Well, you know, hopefully everybody in here recognizes that, again, Chip Paul, Outcomes for Health, hopefully everybody recognizes that if you're a pain management person and you're under the care of the VA, or in most cases just under the care of a physician who's, you know, prescribing you the pain management pills, that you're routinely tested, right? So you're routinely drug tested. And generally, if you fail a drug test for THC, you're kicked out of the program, okay? So literally, the one potential option that is completely safe that we've now given to a physician, you can argue over safety, but again, at no overdoses and since recorded time, right? So again, now we've given physicians this new tool that's completely safe where they can treat, you know, patients in a different way. But we have to change the underpinning, really, culture, you know, and the things that drive, basically the insurance culture that drives those physicians to have to test and, you know, do those things. Again, this is a very well, regardless of what the fella from OSU said last week, and, you know, come on. This is a very well-established treatment protocol for pain, and the anecdotal, again, there's no research evidence here because it's federally illegal, you can't study it, but the overwhelming anecdotal evidence, you know, of how it treats pain, and lots of, and international research. So we didn't talk about that last week, did we? And again, some of the fellows on Dr. Pasternak's list there, if you guys want to talk to real experts, we'll bring real experts here. You know, if it's a lack of information and understanding about how marijuana works, about what literally Dr. Russo is in 6 of those studies, you know, that he just showed up here. So we can, it'll take a little time, you know, you have to arrange it, but we could probably get Russo here to speak if you guys need to hear that level of information. Certainly people like Dr. River, you know, back over there, who's a prescribing physician, it might be good to hear from a prescribing physician at some point. Sorry, I'm on and on.
No, that's good.
Yep.
Lawrence Pasternak, I wanted to add one more little point. The Center for Disease Control, CDC, 2016 guide to physicians for prescribing opioids. The CDC recommends that physicians not concern themselves with THC urinalysis. Pain management doctors prescribing opioids, their recommendation is don't even test for it. They don't see it as a risk to the patient, except a legal risk. So the CDC says to pain management doctors, THC is not a problem.
Very good. Sorry, follow up. And it's again, kind of open. I've heard a few say, but I was wondering if we had any solutions on the table to help solve this in any kind of, I've read so much different legislation, and so I think there's areas there that probably could help, but can somebody kind of clarify if there is any kind of way that we could solve this issue, whichever.
Yeah, and Chip Paul, Outcomes for Health. You know, all of these issues really start with education. Yeah. Okay, and again, how do we drive change in the medical community around marijuana? Well, we take away medical conditions is one way that we do it. And again, that forces the physician to make a determination, and that forces a physician to become educated. They're not clearly real receptive, you know, to that idea just yet. But education is the ultimate answer, because again, if we can educate, I've had great conversations with some big pain management physicians around the state that are very open to this, that work in big hospital systems, but they can't go there yet because of constraints of their hospital system or whatever. So education will drive change, and change is what's really needed, and change at that, you know, physician level, but then policy change as well, like within a hospital or within the VA, although that's federal, or within the way that these pain management clinics operate. But it has to start with education, and they have to understand that someone who's self-medicating with THC is not the problem, right? They're trying to help themselves, but that takes education. So.
And Representative, to your point, Bud Scott, Executive Director of New Health Solutions, what Mr. Paul was referring to, and we were directed by this committee to put together proposals that addressed all of these issues. We've submitted them for your review several times, and they address these issues and more. I think ultimately we need most of these issues resolved, whether it's our proposal or something directly drafted by the legislature. But an action here will only result in litigation and result in patient issues and further lack of clarity as it results to municipalities, law enforcement, our medical community, and where we are now.
Representative Copeland.
Thank you, Mr. Chairman. One of my earlier questions brought the issue of mandatory versus voluntary testing, and then I hear Mr. Scott mention the fact that you can't even do voluntary testing. Is that correct in the state of Oklahoma? Since we haven't been able to get anything done legislatively to fix the testing issue and rules won't be implemented, so that even a voluntary system is not in order at this time?
Representative, it's our understanding that there are no commercially acceptable systems for accepting a test of a Schedule I narcotic for exchange of money and then a return for testing. So it's our understanding that we do not have that authorization in place yet, unless someone else can correct me. But everyone we've spoken to thus far says no.
Follow up.
So, thank you, Mr. Chairman. So, is there any way, all of this has to be done interstate, right? You can't have any testing done out of the state of Oklahoma with any of your products, is that correct?
Yes, Representative, it's illegal to ship anything interstate that's a Schedule I narcotic without a DEA license.
Representative Eccles.
Well, at the risk of taking us back to the reason for today's meeting, could we talk to me a little bit about, we've had the Oklahoma Department of Health, and this is open to the panel. We've had the Oklahoma Department of Health, they came up with a testing protocol. They've said today in the meeting they're open to talking about, even through the rulemaking process, some type of testing protocol. This group and some others have submitted language. To my knowledge, no other group has submitted language other than the Department of Health, which we appreciate. Talk to this committee. Let's drill down into some specifics. Talk to this committee. How did you come up with the language you have? What did you base it on? How does it solve these problems? How does it compare to the Oklahoma Department of Health's language? I mean, let's get serious about the business of if we're going to protect the public, let's get serious about how we're going to do it. So talk to us about that language. How did you come up with it? How does it differ from what the Oklahoma Department of Health had? Was there any interplay with the Oklahoma Department of Health? Prepare me for any issues they may have with it, if at all. Talk to us about that language.
Okay, Chip Paul, Oklahoma for Health. So, and I can talk about, what we did in conjunction with the Department of Health, which I thought we got to a pretty good place, but it kind of didn't make it, to the final cut. But we've certainly talked about testing standards all the way through this. And again, in the 20 pages or so of regulation that the Department of Health produced, the subsequent meeting that we had with them, and again, I don't mean to cast any dispersions, I'm just giving information, but in the meeting that we had with them kind of end of the week before that, we produced a 58-page, draft that I think, certainly we as the activist community all said this is good. And it had testing requirements in it. We did ask that the egregious California, testing standards be, taken out and modified to more Illinois or, Nevada-like looks. But in all of these testing standards, there's commonality in this, right? And it's, again, it all goes back to labeling And it goes back to consumer safety, all right? So what are we going to put on a label? How much medical information are we going to put on a label? And that drives testing requirements, right? So if we're going to put myrcene and linalool and limonene on a label and require that, which I think we should. I think that's a really good idea. Again, that is a way to lead, okay? But if we do that, then that drives testing standards, right? Because you have to test for all that. You have to test for CBDA and THCA and THCV and CBG and CBN and all those things that you already have that's going to be on a certificate of authentication. So just like if you go buy an herb, you get testing, botanical testing for that herb. You'll have a certificate of authentication that has all these things listed. But then there are additional things that have to be tested for public safety. Solvents, pesticides, heavy metals. And that's part of why California's is so egregious, is they've got 50 heavy metals in their testing. But in every single proposal that we've circulated, we account for all of those things, okay? So we account for solvent testing, mycotoxins, pesticides, heavy metals, all of the things that you would expect. In fact, again, I run a natural products company. I, sell turmeric and things like that. There are certain things that you have to do in that world to be FDA compliant. Every single set of testing regulations that have been developed by us or whoever are far, far in excess of anything that I have to do in the natural products world to protect your safety if you go buy turmeric at Sprouts, okay? So these testing standards are far surpass anything that's out there for natural products. So that's the good thing. We're testing in excess of really anything else in the market. But it's necessary. It's federally illegal, so we need to really drill down. But to answer the question, absolutely, the testing standards that we've seen in pretty much every draft circulated have been very rigorous and proper.
And to follow up there, Bud Scott, New Health Solutions, Oklahoma, one of the standards that we used in all of our proposals, and I say ours, I mean both the ones directly developed by our staff at New Health Solutions and then ours in conjunction with all the other organizations, we literally took the language from Colorado's program. This is a cut and paste. We don't need to reinvent the wheel here. And at our Food Safety Advisory Board, we largely adopted the Colorado program there for testing of edibles. That was what came out with some modifications pursuant to input from the advisory board members. But both those and what's in our recommendations are literally directly from Colorado.
By way of a follow-up. So, I'm Department of, I'm putting you a little bit on the spot, so it's okay if you don't know yet. That's always an okay answer. But have you had an opportunity to look at kind of what you guys proposed, what has been proposed? I'm not an expert on testing, so I can read the one they're proposing is a lot longer, but I don't know that that makes it better. I honestly don't know. But have you guys an opportunity to look from the Department of Health's perspective on testing? How does it differ? Is it acceptable? It's been suggested, not by members of the committee. I think it's kind of an offensive suggestion. I won't say that publicly, but it's been suggested that we shouldn't trust these guys because, by golly, they want to sell stuff. By the way, if it's another industry, I would get attacked if I didn't listen to the industry on how to regulate them. But anyway, that's c'est la vie. But so asking it from the Department of Health's perspective, have you had an opportunity to view these? Help this committee. We're not testing experts, and I really want to drill down into what we need to be doing on the testing side, not who should do it, how should do it, who we're listening to. To be blunt, I don't care whose idea it is. I do care that we have good testing standards. So what do you think about the ones that have been proposed compared to yours? What are the issues?
So Buffy Heater, State Department of Health. A couple ways that I'd like to respond to that. So to your first question, have we taken a look specifically at the plans that have been proposed? So those have been shared with us. To be entirely honest, we have not dedicated the resources to be able to do this side-by-side kind of, row-by-row comparison on what that means for the state. However, whenever we talk about the time and resources that have been invested into the Food Safety Standards Board, I certainly participated in those conversations and certainly witnessed the exploration on those half dozen states, how Colorado did seem to line up to be kind of a midline, right, a middle point, a reasonable place for the Food Safety Standards Board to get to in their recommendations. So that's kind of a partial answer there. You'll recall that when Commissioner Bates was here back on August 8th and addressed you all, one of the recommendations in regards to testing is that we, even at the State Department of Health, and I think as we've seen even with our board members on the Food Safety Standards Board, none of us are, Oklahoma lab experts whenever it comes to labs' capability to be able to test medical marijuana products. We really need to continue putting all minds together in a room to be able to share and exchange ideas and to have that healthy dialogue on what is the best path moving forward. The tangible example that I have of that happening from health department's perspective has been the Food Safety Standards Board. So that was a very healthy and productive conversation that had state, private industry, non-medical marijuana private industry, as well as medical marijuana experts, advocates, patient advocates. It certainly helps to have all minds together in the room, and I really have found, in my experience, everyone's trying to get to the same place, which is the best path forward for Oklahoma.
Final follow-up? I say that, I may not mean it, but I think it's a final follow-up. So is it safe to say if I were going to, legislation is supposed to be hard, and I cut to the chase too quick very often, but I don't know why it's supposed to be hard, but it is. Assuming that what these gentlemen tell me is true, that it's cut and pasted from Colorado for the most part, is there any reason to believe that wouldn't be at least a decent starting place for this committee if the panel of experts, and by the way, I love what you did on the Food Safety Commission. Like I've been pleased with a lot of what the Department of Health did. I think they've done overall a great job. Not everything, but overall, I like a lot more of it than I dislike. Would that sound like a reasonable place to start on labeling and testing if that's where the Department of Health fell on food safety?
I would agree with that.
All right. I believe, did you want to respond to his last question?
Would you mind if I just added to Ms. Heater's comments there? One of the things that we saw through that committee was that we also, I think it was Representative Loring that asked about something that could make this kind of unique nationally, Oklahoma's program, was that through some of the proposals that we had through the Food Safety Advisory Board, we took the Colorado program, but then we lessened or lightened some of the burdensome load that could be put upon the actual business people themselves. And instead of having incredibly stringent harvest batch testing or specific test batches where for every product you put out you had to do a test immediately or within a certain time constraint, we really loosened that up to some quarterly testing and then harvest or lot testing as well. So this is a little bit of a departure from what we saw with Colorado specifically that allows it to be a little more functional for Oklahoma's potential industry.
Can I ask a follow-up on that?
Final follow-up.
Yeah. I mean, I actually want to come to some testing regulations and do something. So on that follow-up, will I have the Department of Health here? Because I don't know who else to listen to. The only testing regulations I've been given are from them and your regulations. And like I said, it sounds like there's a lot of similarities there. So does that sound like an issue? If that's the major departure from Colorado, that it's batch testing as opposed to lot testing, whatever that means. Is that a major issue, or what are your thoughts there? Yeah, if you have any. By the way, this is way putting you on the spot, so I don't know. It's always okay.
Yeah, well, and I've already issued the disclaimer that I'm not a laboratory scientist myself, right? Policy wonk, that's my title. So I think there, for clarity purposes, right? So from a rulemaking perspective, my suggestion would be, rather than limiting it to just batch or just lot, let's define both of those terms so that the the recipients of the rules, right? So the industry that's trying to take these rules and say, what does this mean for our business practices? They can see where the state is coming from in terms of what the difference is between a batch and a lot, and also give some autonomy to those businesses to be able to self-identify the size of those samples, because that is something that the Food Safety Standards Board did recognize, is that rather than having a prescribed for every business type, no matter if you're a huge commercial to a very small mom and pop shop, rather than setting those standards from a state level to say it shall be this size and this shape, give some autonomy to the business to be able to self-identify, just making sure that it is adequate to ensure the products that are going out the door have enough quality controls on them and have enough successful tests that the majority of the batches are going to be tested and safe, right?
No more from us.
Thank you very much, and that's actually, I believe, a great jumping off point to close out here. I want to thank everyone for being here. Thank you for the dialogue. Started this meeting by saying that this is the meeting I've been waiting for. I think if nothing else, we've got to figure out testing. We can debate all day about the proper role of government, but I don't think anyone in here doubts that part of the proper role of government is to make sure that the people of Oklahoma have safe medicine. And so that's what we're here to do. Information for the committee members, and I guess for everyone at whole. Next week, we will be on lab testing again. We have 2 presenters coming next week. One is from a national association who's going to give us a presentation very much detailing and laying out what different states have done and kind of what they've learned from that process to give us, and it'll be someone where we can have the opportunity to say, okay, we've picked Colorado because we believe that's a midpoint. Is that really the midpoint? And so we'll have that speaker, and then we will have the opposite of Ms. Heater. We will have a lab testing type guy. We will have a scientist who can help us answer some of those questions, go a lot into the terpenes and some of those conversations. Go home this week, do studies on terpene and lab testing and equipment and everything else. But with that, we will be adjourned until next Wednesday. Thank you.